Hi, I'm Connie Slayton. I'm Alex's mom, and she told me that um, she needed help with her project and to interview someone with my profession. My profession is I am a hospice nurse. I have worked in the hospice field since 2009, so a good bit. I work for a family owned hospice agency called Personal Touch Home Care and Hospice, which is located in Newport News and City Center. We are the largest non-hospital based hospice company in the peninsula, because when you hear of hospice around here, you probably hear of hospice agencies that are associated with Riverside or Centera. We are not. We've been in business since 1974, and like I said, we're a family-owned company headquartered in New York. Um, what education courses that I took to be eligible for this position? I have my BSN, which is a Bachelor of Science in Nursing. I received that in 1997 from Christopher Newport University. And with nursing, you go into different fields. You specialize. You can be an oncology nurse, a med surgical nurse. Hospice is kind of a different specialization. It takes a special person to be in hospice because you are around death a lot. And I also do a lot of social work. So, and in fact, with some nursing, with hospice too, you do a lot of social work as far as not just taking care of the patient, but taking care of the family. My daily routine, nothing's the same. With some nursing, if you're a pediatric nurse and you work in an office, you're seeing kids for certain things 9 to 5. With hospice, you're basically dealing with, like I said, dealing with death. People declining at different stages in their disease process. But we have a caseload of, I think right now we have about 32 patients on our census at all stages of their disease. And with hospice too, some people think, cancer. But a hospice patient could be someone with congestive heart failure, could be someone with kidney failure, Alzheimer's disease. Basically, to the criteria for hospice, a doctor has to give them basically 6 months or less. It's horrible saying that, but the insurance obviously plays a huge part in this field. So to be eligible for the hospice benefit under a patient's insurance, they have to be deemed a terminal diagnosis within 6 months. And you might say, how does a doctor predict that? And how can a doctor predict a patient has less than 6 months to live? But it kind of is, of course, an estimate, but the doctor does look at all types of their disease and where they're at and what stage they're at to certify them under the hospice benefit. But I'm kind of off track. So we have about 32 patients on our census. So every day we do round with those patients. We see where they're at, who may need a visit. Under skilled care, under the home health benefit, a patient may be seen, 3 times a week. For a nurse. Hospice is a little bit different. We might go out to see a patient 1 day a week, but as they decline, then we go as needed. And like I said, we do take care of the patient, of course, but under hospice, we do a lot of care for the family. We provide respite care, so if a family member who needs to go out of town for vacation, we can provide respite care for them so they can go and enjoy themselves. Hospice is very grueling on the family. Some people think, when they do elect hospice that it's 24-hour care. It is not. That is a misconception of hospice. The family has to be very, very involved because as the disease changes, they do require 24-hour care as they progress and start to decline. Under hospice too, if the patient is very spiritual, we do have a chaplain on staff that can come out and make visits and meet with the family and the patient. We also have a caseload of volunteers. If the caregiver needs to go run to the grocery store, a volunteer can come and sit with the patient. If they need, sometimes we have strange requests. So, if they need yard work done, we have volunteers that can come and help with that, and so forth. Under Hospice 2, that does mean that they have elected to cease any kind of curative treatment. Um, so our goal too with hospice is to take care of the patient. If the patient wants ice cream, that's what we do. We're supposed to keep the patient's quality of life at the end of their life um, completely pain-free and be able to spend time with their family at the end stages. So if a cancer patient, is still, wanting to fight the disease and have, try a new drug, um, they wouldn't qualify for hospice. So when we hear patients say, I am tired of coming in and out of the hospital. I am tired of the side effects of this medication that, is giving me. I'm tired of getting sick and feeling like I'm, nauseous all the time. Those are cues too that we take that we think, or the doctor too, and the doctor's office thinks, what, this patient, might be ready for hospice. They are declining. They are tired. They don't want to go in and out of the hospital every couple weeks. So that's when we might do, a hospice informational and talk to the family, see if they're ready. Sometimes the patient's ready and the family's not. So that's why with hospice too, we do again take a lot of care of the family. We could have the family that might be saying, we want to try this clinical trial. We want to take them to Duke Medical Center and go do this X, Y, and Z. But then the patient might be like, I just really don't want to do that. So we also want to make sure that we are the patient's voice and try to have those sensitive conversations with the family as they accept the fact that their family member is at the end of life. So when the patient is declining and passes, they'll pass at home. That's the whole point of hospice, is being at the home and not at the hospital, surrounded by their family members. We do go out and pronounce the patient as being deceased. We then try to help the family with any kind of funeral arrangements, any kind of medical equipment that needs to go back, and just kind of be there for the family, talk to family members if we need to, and so forth. Any interesting encounters I've experienced, I think, under hospice when you're with someone as they pass, it's a very special experience. It's hard to explain and put into words because, we've had patients that are, your typical, maybe over 90 years old, where they've lived a great life. They're surrounded by, family and friends, and their wishes to be home have been met, and they've lived their life. We have some experiences where we have someone my age. I had actually a patient that passed away January 19th. She was a 45-year-old mom in Williamsburg with two daughters that I have, and she passed away from stage 4 breast cancer. And it's very disheartening sometimes to be around that because it does hit close to home. I'm 42 years old, and you try to be there as much as you can, and be there for their children. You also become part of the family when the patient's on hospice. And you have in this instance, I had a husband that didn't know what to do. He was not used to running the show in his family. His wife was. She was the backbone of the family. 45 years old and passed away, and she had 2 young girls. So that was a very, I wouldn't say interesting experience. It's just a different experience because you see all types. Cancer does not discriminate. Neither do Alzheimer's, renal disease, congestive heart failure. No disease discriminates. So you see all types of people. You see people who, are very wealthy. We see people who live on in Denby on Chestnut Avenue down in Newport News. Everybody deserves to have their final wishes met, and that's what we try to do with hospice. How it relates to anatomy and physiology. Let's see. It is nursing, so you do deal with, all the different types of diseases. You can see, especially the different stages of death. I can tell sometimes, being in nursing, when you can see when organs start to shut down, when the patient's coloring changes, when they're not alert and oriented, their body temperature changes. Sometimes it happens very fast. I've had some cases where I've been talking to a patient who is alert and oriented times 3, and then the next day they do not even recognize me. And then we've had cases where, you almost pray that something happens because, they are struggling for weeks. So I would say it's just being knowledgeable of the different diseases, especially with heart, cardiac, oncology, renal. Those are the type 3s I would say that I see on a daily basis. Although Alzheimer's is probably the new up and coming hospice diagnosis that is, I would say, around. One thing I can say that patients don't do enough. I mean, there's not enough sometimes hospice education that's out there. When people do think of hospice, they think death. We have had graduates of hospice, believe it or not, that have come on under hospice and have actually gotten better, and we've discharged. Some doctors, though, I feel don't believe in hospice. Some do. Some doctors feel like they want to treat till death, and you sometimes look at the patient and think, that's when we look quality of life versus quantity of life. This patient is miserable. Their cancer has spread. When a patient is stage 4, they are terminal. It has metastasized to another organ. And sometimes the doctors, believe it or not, don't want to have those tough discussions, and that's where us nurses come in. That's where we, get with the family and talk with them and make those tough decisions together as a unit and see how they want to proceed and try to embrace the final wishes of that patient. Trying to think what else, where I was at the anatomy versus physiology part, and I talked a little about education. The benefit too of hospice is, not waiting until the patient is declining so rapidly, and they're like, oh, we want hospice. We want to come home from Riverside today with your hospice program. Sometimes we'll turn those referrals down. Hospice too, the best benefit that the family and the patient can give is electing it early. Having those discussions early enough. If they are deciding that they do not want to seek any more curative treatment, instead of waiting, go ahead and elect hospice now so the family and the patient can get the full benefit of hospice. When we have those cases where they want to fight, and that is definitely their right to do that with their disease, the hospice experience sometimes can be very traumatic. So those referrals sometimes we do not take. And we've had one where I didn't know if the patient was going to even make it home in the ambulance ride coming home. And that's very traumatic. In that regard, we would just prefer that the patient stay in the hospital and pass away peacefully at the hospital. At Riverside Esoteric Careplex, for instance, there is an inpatient hospice unit there where they do reserve a couple 2 to 5 beds of patients who possibly would want hospice but maybe might not make it home. And there also is a great house, actually. It's called the Hospice House. It is in Williamsburg, and they have 8 beds there, and it is a beautiful home that is run exclusively of volunteers. You have to meet certain criteria to be admitted. I think you have to be a Williamsburg or Yorktown resident for that, and also have to be at a certain stage in your disease process. Usually, in this regard, they'll accept patients when the doctors say they might have, 2 to 4 weeks left, and they will be, if the bed's available, they'll be admitted there. The families can stay there overnight. They have a huge kitchen. Meals are cooked for the family and for the patient as tolerated. But it is decorated beautifully. It is very peaceful, and that is a wonderful facility that if a bed's available, that I would love for my patients to go to, because, too, it kind of helps a little bit more on the caregiver side of a 24-hour around-the-clock nurse there. Another great facility is the VA. The Veterans Administration. So that is a benefit of a veteran. They have an inpatient hospice unit there at the VA, which is gorgeous. I don't know if you've ever seen the Hampton VA, but it's on the water there. It has glass windows, a beautiful bed, and an actual little separate side bedroom for a significant other or caregiver to stay the night with their loved one and be there while receiving around-the-clock care, hospice care. So there are some resources out there. So when I did talk about social work too, that was a little piece of it, because with hospice, like I said, it's taking care of the patient, but we're definitely taking care of the whole family unit. And not one case is unique. They're all different. Like I told you, I dealt with a 90-year-old patient. I could deal with a 45-year-old patient. I don't deal with any pediatric patients, and I'm blessed that I have not had that in my career. But there is another a hospice company that does deal too with pediatric patients, and those are children under the age of 18. So I think that's all I have. If there's any questions with what I do, Alex can definitely get those to me, and I'll be happy to answer them. So thank you very much.